Imagine a state-of-the-art security system, like the kind you might see in a high-tech facility or
Oh,
something.
yeah, like super high security.
Right, exactly. So under normal conditions, you swipe the right badge, the little indicator light turns green, and the heavy glass doors just slide open completely seamlessly. Like everything operates on this automatic underlying protocol.
Right. It's just a frictionless process. The system doesn't even have to deliberate. It just, recognizes the authorized signal and allows access.
But if that exact same system detects a threat, say, I don't know, a fire alarm triggers or sensors pick up an intruder, it doesn't matter how hard you swipe your badge or how authorized you are.
Yeah, the protocol shifts entirely.
Exactly. It initiates a total lockdown.
Yeah.
Heavy steel blast doors slam shut, the alarms sound, and the building actively protects itself by, well, restricting all access.
And that override is instantaneous. And, importantly, it's completely out of the hands of the person standing at the door. The system's primary directive just shifts from accessibility to pure survival.
Right. And that security system analogy is pretty much the perfect lens for what we are analyzing today. Whether you're, a medical professional catching up on research or just an insanely curious learner, we're looking at a deeply complex intersection of human biology and psychology today.
It's a really fascinating area.
It really is. We're driven by this specific question for this deep dive. Can chronic relationship stress, or even just unspoken intimacy conflicts, cause a somatic physical presentation of severe, unyielding vaginal dryness?
It is a profound mechanism to explore. Because we're looking at a physical symptom that affects an enormous number of people, yet it remains shrouded in so much stigma.
So much stigma, yeah.
Right, mostly because it is so frequently misinterpreted as a lack of attraction rather than what it actually is, a biological defense mechanism.
Exactly. And to understand the actual mechanics at play here, we're pulling from a pretty comprehensive stack of clinical data. We've got guidelines from the American College of Obstetricians and Gynecologists, or ACOG.
We also have extensive clinical reviews from BMJ Best Practice.
Yep. And research from the International Society for the Study of Women's Sexual Health. Plus some really detailed symptom progression notes from UB. So our mission today is to map the biological circuitry connecting the brain, emotional stress, and the physical mechanics of female arousal.
And specifically looking at how unresolved relational issues can, throw the body's lubrication system into that exact total lockdown mode we just talked about.
Right. Because the clinical literature really requires us to view the human body not as like a collection of isolated parts, but as this integrated network.
Yeah, a network where the autonomic nervous system and your emotional state are entirely inseparable. You just can't pull them apart.
So let's ground this by looking at how the system functions when there is no threat detected.
Yeah.
Because if we want to understand how chronic stress breaks the mechanism, we first have to understand the baseline biology of wetness.
That makes sense. We have to know what normal looks like.
Right, because reading through the ISS-WSH guidelines, the actual physiological process of lubrication is wildly different from how it's portrayed in popular culture. It's not just, getting wet.
Oh, not at all. The medical term is actually vaginal transudation.
Vaginal transudation. Okay.
Yeah, and it is a highly orchestrated vascular event. So the vaginal wall itself does not actually have glands that just secrete fluid.
Wait, really? Because I feel like most people assume it's like sweat glands or something.
Right, it's a super common misconception.
Right.
But instead, during sexual arousal, the parasympathetic nervous system signals the blood vessels in the pelvic region to dilate.
Okay, so the parasympathetic, that's the rest and relax system, right?
Exactly. So blood flow to the area increases dramatically. And this massive increase in vascular pressure forces blood plasma to literally filter or transsude through the epithelial cells of the vaginal wall.
Oh, wow. So the fluid is essentially a byproduct of intense localized blood flow.
It is a direct result of vasocongestion. The tissues swell up, and that internal pressure just pushes moisture right to the surface. But this transudation process relies on a very specific biological environment to work.
Okay, what kind of environment?
Well, first, there needs to be adequate estrogen in the system. Estrogen is what maintains the thickness, elasticity, and the, structural integrity of those vaginal tissues.
So they can actually handle the fluid transfer.
Exactly. Second, you need the nitric oxide pathway to function properly to dilate those blood vessels. And third, governing all of this is that parasympathetic nervous system.
Right, the body's rest and digest command center.
Yeah, it's the network for all bodily functions that occur when you are feeling safe, calm, and secure. Digestion, cellular repair, sexual arousal, They are all parasympathetic processes.
Okay, so the brain is the absolute starting point for the sexual response cycle.
100%. If the brain processes the environment as safe and comfortable, it basically gives the parasympathetic nervous system the green light. Vasocongestion happens, fluid transduces, and lubrication occurs.
I want to push back on something here, though, regarding a massive societal misconception. Because the clinical data is very firm on this, and it completely shatters this pervasive cultural myth.
Well, I think I know which myth you're talking about.
Yeah, there's this enduring idea that if a woman isn't wet or is experiencing severe dryness, it must mean she isn't attracted to her partner or she's, doing it wrong.
hmm
Can we debunk that using the medical data?
We absolutely can, and we should. The clinical data fundamentally rejects that idea. Physical arousal, meaning that vascular process of lubrication and emotional desire are governed by overlapping but separate neurological systems.
Separate systems, okay.
Yeah, you can experience profound emotional desire and attraction without producing a single drop of physical lubrication. And conversely, physical lubrication can occur in the complete absence of emotional desire. It can even happen during non-consensual encounters, simply as a localized reflex to friction.
Because it's not a conscious choice.
Right, exactly. You cannot will your body to initiate vaginal transudation any more than you can consciously command your pupils to dilate or your sweat glands to start sweating.
I mean, that makes total sense when you put it like that.
Yeah. If a woman's brain is saying, I love this person, I want to be intimate, but her autonomic nervous system is sensing some kind of underlying stress or threat, that vascular response is going to be intercepted.
So the lack of lubrication is really just a biological metric of what the autonomic nervous system is prioritizing in that exact moment.
Perfectly said, yes.
Well, so if the baseline requirement for this vascular event is a parasympathetic state of safety, what happens biologically when a person's dealing with chronic stress? Like, how does the sympathetic nervous system, the fight-or-flight mode, hijack this?
Well, when you are dealing with chronic anxiety or just the mental load of a demanding career or financial strain, your amygdala registers a threat.
And it doesn't know the difference between, like, a literal bear chasing you and a looming mortgage payment, right?
Exactly. It doesn't differentiate at all. The sympathetic nervous system just takes over, and its only goal is survival. So it immediately restricts blood flow to the digestive tract and the pelvic organs.
Oh, and it redirects it to where?
To your major muscle groups, your heart and your lungs.
Man, it's kind of like trying to download a massive file while running a really heavy video game on your computer.
Oh, that's a great way to think about it.
Right, like the brain is already using way too much energy and processing power just being worried and stressed. It simply fails to relax enough to let natural physical reactions run in the background. The vasocongestion is literally starved of the blood flow it needs.
Yeah, because the body thinks you need that blood in your quads to phonically run away. The localized blood vessels constrict. But the interference isn't just physical, it's chemical and systemic over the long term.
Okay, tell me more about that.
The BMJ best practice reviews dive really deep into this endocrine disruption. Chronic stress persistently elevates your primary stress hormone, cortisol.
Right, cortisol.
The stress hormone.
Right, and the biological pathway for stress is the HPA axis, the hypothalamic pituitary adrenal axis. When this axis is constantly firing and pumping out cortisol, it actively suppresses a parallel system, the hypothalamic pituitary gonadal axis.
Which is the reproductive axis.
Exactly. High cortisol inhibits the release of gonadotropin-releasing hormone from the hypothalamus.
And without that hormone, what happens?
The pituitary gland stops signaling the ovaries, which means estrogen production plummets. So it's basically a double penalty. In the short term, the sympathetic nervous system is actively restricting the blood flow needed for the fluid. And in the long term, the chronic cortisol is eroding the estrogen required to keep the vaginal walls healthy anyway.
It is a remarkable display of evolutionary biology, really. The human body is exceptionally pragmatic. If the brain perceives that you are living in a chronic state of threat, it calculates that this is a very dangerous time to reproduce.
Or even just to be in a vulnerable, intimate position.
Right. Reproduction is downgraded to a non-essential function, and the structural integrity of the pelvic basin is placed on the back burner.
So if ambient life stress, like just a bad day at work, can trigger this and shut down the pelvic organs, then relationship dynamics must have a massively amplified effect, right? Because sharing a bed with the actual source of your stress has to send the nervous system into overdrive.
Oh, absolutely. The clinical literature confirms that relationship dynamics are one of the most potent triggers for this somatic presentation.
I can imagine.
Yeah, when we look at the data on dyspareunia, which is the medical classification for painful intercourse, the BMJ reviews note that interpersonal conflict is identified as the primary contributing factor in roughly 27% of all cases.
27%, that's huge.
It is. We are looking at factors like poor communication, unresolved anger, feelings of overfamiliarity, or even just a subtle struggle for control within the partnership.
And the ISS-WSH data also points to internal psychological factors that stem from the relationship, right? Like a woman feeling coerced or obligated or internalizing these passive gender roles where she feels she exists just to service her partner.
Yes, all of that generates a massive amount of internalized guilt and anxiety. When a relationship lacks foundational emotional intimacy and trust, the brain literally processes the bedroom as an emotionally unsafe environment.
Wow, so the body just physically absorbs the tension of that unspoken boundary.
Exactly.
Which brings up a really crucial question. Wait, so a woman might actually want to be intimate to, fix the relationship. Or maybe she feels pressure to just go through the motions to please her partner, but her body goes rogue and physically says no.
Yes, and it is a profound source of distress. We see it constantly in the clinical notes. When intimacy shifts from an act of mutual connection into um, a technical problem to be solved or a duty.
A chore, almost.
Right, a chore. It introduces performance pressure.
Yeah.
And performance pressure is inherently sympathetic. The moment the brain feels pressure to perform, the parasympathetic rest and relax state is just obliterated.
So the security system senses the anxiety and the resentment, and it just throws the deadbolts.
The unyielding dryness in these scenarios is essentially the body's unconscious, automatic protective response to emotional unsafety. The conscious mind might be saying, let's just get through this, but the autonomic nervous system overrides that.
Right.
It evaluates the relational tension and dictates that the gates remain closed.
And when the body says no, through that severe dryness and a couple attempts to just push through it anyway, it creates a whole new physiological nightmare, doesn't it?
It really does. Ignoring that somatic boundary transforms a problem of arousal into a complex pain disorder.
Because of the friction.
Exactly.
Yeah.
The immediate consequence of attempting penetration without adequate transitation is severe friction. The vaginal epithelium is incredibly delicate. Friction causes micro tears in the tissue, leading to acute burning and stinging.
Which is the dyspareunia we mentioned earlier.
Right. And once that physical trauma occurs, the brain logs it. The brain is fundamentally a prediction machine,
Yeah.
It uses past experiences to predict future outcomes to keep you safe.
So once the neurological pathway associates intimacy with pain and tissue damage, what happens?
A new, completely involuntary reflex arc is established. This is where we see the development of vaginismus, or hyperconic pelvic floor dysfunction.
Okay, the clinical notes from UBI describe this progression in detail. We're moving from just a lack of fluid to an active muscular defense mechanism.
Yes, the pelvic basin is supported by a complex network of muscles. In a patient who has developed an association between penetration and pain, these muscles, specifically the levator any group, become hypertonic. They enter a state of chronic abnormal tightness.
So they just lock up.
Exactly. When penetration is even anticipated, before any physical contact is even made, these muscles involuntarily spasm and contract to physically block entry and guard the tissue.
It's basically the exact same physiological response as flinching before you get a shot at the doctor's office.
Oh, that's a perfect comparison.
Yeah, like you know the needle's coming, so your body reflexively braces for impact. But because you're tensing the muscle, the needle actually causes more tissue damage and hurts way worse.
Yep.
And then, because it hurt worse this time, the brain trains itself to flinch even harder the next time you go to the clinic.
The pain tension cycle is entirely self-reinforcing. If we zoom out, the cascade looks like this. Unresolved conflict causes stress. Stress stops lubrication. Sex hurts. The brain associates intimacy with pain. Severe anxiety builds. Pelvic muscles spasm defensively. And then sex becomes physically impossible.
A purely emotional conflict has physically altered the tension of the pelvic floor muscles to the point where they act like a concrete wall.
Exactly.
So knowing that this unyielding dryness and the muscle spasms are a completely valid somatic response to stress, how do the clinical guidelines recommend breaking this painful loop? Because, you clearly can't just tell someone to relax.
Oh, definitely not. Telling someone to relax usually does the exact opposite. The consensus across ACOG, BMJ, and ISSWSH is that treatment must be concurrent. You can't isolate the psychological root and ignore the tissue damage.
Right.
Nor can you treat the physical symptom without addressing why the nervous system is in lockdown in the first place. It's a multi-pronged approach. First, you address the anxiety and relationship conflict through CBT, mindfulness, or psychosexual therapy.
Re-establishing a sense of safety so the parasympathetic nervous system can actually come online.
Right. Second, you have to allow more time. The biological process of transudation requires a runway. The literature notes that natural lubrication often requires 20 to 30 minutes of relaxed, pressure-free arousal.
Rushing the process is a massive lubrication blocker.
It really is. And third, use physical support. The guidelines strongly recommend water-based or silicone-based lubricants during intimacy and vaginal moisturizers applied 2 to 3 times a week to restore tissue health.
I want to pause on this for a second because for a lot of people listening, reaching for a bottle of lubricant might feel like, I don't know, a personal failure, like an admission that the relationship is broken or they've lost their spark. Can you reframe this based on the clinical consensus?
I'm really glad you brought that up. From a clinical perspective, that stigma is not just unfounded, it's actively harmful. Medical professionals universally agree that using lubricant is healthy, normal, and frankly, an essential therapeutic tool.
Essential?
Yeah. If a patient is caught in that self-reinforcing pain tension cycle, you have to break the loop of tissue damage to rewrite the brain's prediction algorithm. Treating the physical symptom with lubricant is just as important as treating the emotional root.
Because restoring pain-free comfort is required to signal to the nervous system that intimacy is safe again.
Exactly. You cannot convince the amygdala to turn off the fight-or-flight response if the physical experience is actively causing friction and microtears. The physical intervention provides the proof the brain needs.
And then finally, for hypertonic pelvic muscles vaginismus, the UB clinical notes highlight the efficacy of pelvic floor physical therapy, right?
Yes, pelvic floor PT is highly successful. It uses systematic desensitization. Physical therapists guide patients through deep muscle relaxation, often utilizing vaginal dilators of gradually increasing size.
So it's about retraining the brain in a totally controlled environment.
Exactly, proving that penetration does not have to equal pain. It gives the autonomic nervous system the evidence it needs to finally stand down.
Man, pulling all of these clinical threads together, the overarching takeaway from this deep dive is just such a profound reframing for the listener.
It really is.
Unyielding vaginal dryness isn't necessarily a sign of a broken body. It's not a lack of love, and it is definitely not a personal failure. Very often, it is the sign of a highly functioning nervous system doing exactly what it evolved to do.
Protecting you from perceived emotional or physical threats caused by, chronic stress, pressure, or unspoken relationship conflict.
Right. The security system hasn't failed. It's functioning perfectly. It's just responding to an alarm that needs your attention at the source.
It leaves you with a really provocative thought to mull over.
Oh, what's that?
Well, if our bodies are this incredibly adept at physically manifesting our unspoken emotional boundaries by literally closing the doors and shutting off the blood supply, what other mysterious chronic physical symptoms might we be ignoring?
Oh, wow. That's a great point.
Right. What other tensions or localized pains might actually just be our nervous system trying to have a conversation with us that we've been avoiding?
That is so true.
Yeah.
The next time you experience an unexplained somatic response, maybe the first question shouldn't just be how to medicate the symptom away, but rather what underlying alarm tripped the system in the first place.
Exactly. The body's triage protocol rarely activates without a valid reason.
Because when that state-of-the-art security system throws the deadbolts, it isn't trying to punish you, it's just waiting for you to clear the threat, so it's safe to open the doors again.